MD and DM in cardiology, and he is additional professor of cardiology in All India Institute. He is, presenter par excellence and presenting number of webinars, lectures. In fact, he had one yesterday itself. So he has a large number of publications in international and national indexed journals, and his special interests are being morphoanatomy of congenital heart disease, cardiac hemodynamics, and the best part, what he is doing is a virtual dissection. Very few people are doing it. This is something which is very, very exciting with the current high CT. Uh, so over to Dr. Sourabh.
Yeah, thank you, Dr. Singh. And at the outset, I must thank Dr. Singh for having me for the meeting. And as always is the case, let's come to the point directly. I'm sharing my slides. I hope the slides are visible and I'm audible.
Yes, sir, all done.
Yeah, so I think I have 25 minutes, but I'll try and cover this in 20 minutes. And if there are questions, I'll be happy to take. So the topic is role of echocardiography in planning surgery for Tetralogy of Fallot. And in today's time, this is probably one of the most important things we must recognize, that unlike maybe 2 decades back, diagnosis is not the end, but the beginning of practice. Because where we used to end 2 or 3 decades back, there we are starting now. Diagnosing TOF is not a big deal, but now how to manage is the question. And that is why probably we are discussing this topic today. As we all know, Tetralogy of Fallot is the most common cyanotic congenital heart disease beyond infancy. Only definitive treatment is surgical repair, and quality surgical repair is the goal, not just any surgical repair, because outcomes totally depend upon the surgical repair, how it is done and what techniques are being used. Now, it's very challenging in current times to keep pace with the medical explosion of medical knowledge. As you can see in one of the study which was done in, one prediction which was made in 2011, they said that by 2020, the doubling time of medical knowledge would be 73 days. So it's not just the attendees, we all feel the heat of this expansion, and we keep finding it difficult to keep pace with the knowledge. So these CMEs are there to bring us back to what is needed for us. So this is what is tetralogy. So we have 4 components: a malaligned VSD at subaortic region, pulmonary stenosis because of this malaligned anteriorly deviated septum, narrowed right ventricular outflow, overriding of aorta, and secondary to pressure and the volume of pressure overload of right ventricle, there is right ventricular hypertrophy. Now, before we go on to understand the echo, it is very important that we understand the morphology and what is being done during surgery, because then only we can do echocardiography properly. So these are the 4 components again. This is the VSD, subaortic. Here, there is aortic override. This is deviated septum, narrowed outflow. This is the pulmonary valve, and then there is right ventricular hypertrophy. Now, there are some variants of tetralogy: AVSD with TOF, TOF with pulmonary atresia, absent pulmonary valve, anomalous origin of pulmonary artery, and we will not be talking about these because that is for a different talk probably. Now, one thing before I go on to TOF proper, I would like to say that subaortic VSD with aortic override is not equivalent to TOF. So for TOF, you need to have this septum anteriorly deviated with a narrowed right ventricular outflow tract. So sometimes on echo, we tend to make this mistake. If we see a subaortic VSD and aortic override, we tend to think that we are dealing with tetralogy, but that is not the case. We must always document right ventricular outflow tract obstruction before labeling a case with tetralogy. Now, the important thing is not all tetralogies are same. Variation is actually the norm. VSD can vary in its size, extent, and inclusion of adjacent structures. Aortic override is also variable. RVOT obstruction can also be subvalvular, valvular, supravalvular. Pulmonary arteries may vary in its size. Sometimes they may arise even from aorta. Ostial stenosis, left pulmonary artery is quite common. Aortic valve is somewhat rotated clockwise, and because of that, coronary anomalies are not uncommon in tetralogy of Fallot. As you can see over here, up to 3 to 5% of patients with tetralogy have coronary anomalies. And more importantly, these coronary anomalies may have surgical implication. We'll see how. Now, I think some of you would have seen this trap door. So this is what happens, that there is a trap door which opens towards RVOT. And during surgery, what we are trying to do is we are closing this door while making this path unobstructed. In that process, what we can do is we can put a valve patch at that VSD. We have to open this narrowed segment, and in that process, if the pulmonary valve annulus is small, we have to put a patch that is called as transannular patch. If that is not possible, if the pulmonary arteries are small, then sometimes we give aortopulmonary shunt. So BT shunt or modified BT shunt, that is also given in these patients. Now, this is another diagram I would like to draw your attention to. As you can see over here, this is probably what we know as VSD, but this is what the surgeon would be closing. So we have to be mindful what would be the anterior margin of aorta in relation to the ventricular septum. That is the one which is being closed by the surgeon. And we have to be mindful how much space is being occupied into the right ventricle. And that would be determined by the aortic override. You can imagine if this override is more, a lot of the space of right ventricle is being occupied by this aorta, and that may make right ventricle smaller. And that is why greater is the override, it may be difficult to do a surgical repair. Now, TOF repair has come a long way. What we have learned is unrestricted pulmonary regurgitation is not good, ventriculotomy is not good, and preserving pulmonary valve is good. So earlier on, it used to be transventricular repair. Now it is transatrial repair. More and more surgeons are doing, and we believe that this is much better approach than doing a transventricular repair. Now, transannular patch is another thing which is not mandatory, unlike which we may be thinking. If the pulmonary valve annulus is good size, as you can see over here, if annulus size is within -1 z-score, it can be complete transatrial transpulmonary repair without transannular patch. Even if it is borderline small, you can avoid transannular patch. If it is small, then you will need transannular patch. And the good news is approximately 50% of tetralogy of Fallot may have a pulmonary valve annulus where you can save the pulmonary valve without putting a transannular patch. And that is very important. And that is the crux of this analysis of echo. It is not just the heart that matters. It is the pulmonary artery probably which will determine the immediate surgical outcome in these patients. If the PAs are too small, you cannot do a surgical repair, and this patient has to go for palliation of some sort. Now, there are valve sparing TOF repair, where again, morphological characteristics of pulmonary valves are important. And there comes the role of dedicated detailed echo. So you have to see the z-score of the pulmonary valve annulus, number of cusp of these annulus, orientation of commissures, and degree of dysplasia. If it is a thickened valve, it is very difficult to repair. If it is a thin pliable valve, they may use this valve for valve sparing surgery. Now, apart from anatomy, physiology also matters. Chronic hypoxia may cause LV dysfunction. Long-standing RV overload may cause significant right ventricular hypertrophy, leading on to RV diastolic dysfunction, and that may behave like restrictive RV physiology, which is one of the causes of poor cardiac output in post-operative period. So what we need to do during echo is we need to do a detailed anatomical assessment, all the variables which is going to determine the surgical repair. Number two, we need to assess the physiology of both the ventricles, how it is going to behave after surgical repair. Moreover, surprises are not always good. And that is why you need to give as much information as possible to the surgeon so that they don't come back and say that this was not known to us. This is what is prototype tetralogy of Fallot, subaortic VSD with aortic override, anterior deviated septum, and narrowed outflow, and RPA and LPA. So this is one of the standard tetralogy of Fallot, which is suitable for TOF correction. We'll go along with echo assessment by taking two examples. So this is 8-month-old infant with tetralogy of Fallot, no cyanotic saturation 80%, weight 6 kg, length 65 centimeter, and body surface area 0.32 meters square. The importance of these numbers, I'll come in. This is another important thing. I thought that this is right forum to introduce you to the concept of timing of surgery. Not like 1 or 2 decades back when we would wait for tetralogy repair up to say 2 years, 2.5 years, 3 years. Nowadays, we can easily operate these patients anytime after 6 months. So 6 months to 12 months is the correct time for tetralogy repair. If they are symptomatic before that, depending upon the pulmonary artery anatomy, they may still be sent for surgical repair. Now coming to echocardiography, you start with the situs. If aorta is to the left, IVC is to the right, then we are dealing with abdominal situs solitus. There are other ways, and I think it has been dealt with in previous talks. I'll not go into the details of that. You confirm AV connection. Here, the right atrium is connected to a ventricle which has a apically displaced valve, which is a tricuspid valve. And if you are carefully seeing, there is a moderator band which makes it right ventricle. So right atrium is connected to right ventricle, left ventricle is connected to left ventricle. So AV connection is normal or concordant, and there is a ventricular septal defect over here. If you tilt the probe further to apical 5-chamber view, I am using the same views which adult people are more used to, so that we use this information while this is being done by colleagues from adult cardiology. So this is a large subaortic VSD with bidirectional flow. Same thing, if you do an anatomic orientation, I think for us, it makes more sense because up is up, down is down, left is left, right is right. And therefore, you don't need to think again. Here you can see there is a VSD here, and there is a narrowed outflow, which is also seen. Now, this is aortic override, which is minimal on parasternal long axis view. But if you do the same thing on subcostal view, as you can see over here, override is not as less as it was seen in plex view. So subcostal views are slightly better in terms of defining override. Now, focus on the aortomitral region is important. Now, aortomitral discontinuity, unlike what so many people believe, may be indicative of DORV. I think that that is not the case. Even in presence of aortomitral discontinuity, you cannot label a case with, as DORV, because what we are trying to say is that this patch has to close this VSD. So if it is like going to be closed like a tetralogy, then we call it tetralogy. And having aortomitral discontinuity is not the sole reason why you should label a case with aortomitral discontinuity as DORV. Now, we again look at the flow across VSD. In normal, usual tetralogy, it is unrestricted flow. If it is restricted flow, we call it Hoffman variant. If there is restriction, it further causes pressure overload into the right ventricle. And in those cases, right ventricle is under strain. It may have suprasystemic pressure, and that is an indication of early surgery for these patients. Now, additional VSD is very important thing. And when we evaluate for additional VSD, mind you, RV is at the same pressure as LV. So it is very difficult to get the jet which you are expecting when you are seeing a muscular VSD in a normal heart or hearts with otherwise, a single or isolated VSD. So here it is very important that we reduce the Nyquist limits to lower scale and then scan the septum from left to right, apex to base, and so that we don't miss out on any additional VSD, because the pulmonary vasculature in tetralogy is used to low pulmonary blood flow. And if these patients have additional VSD, which is ignored or is not identified and is there after surgery, it shunts a lot and the patient behaves very badly. So it is very important to identify additional VSD by looking at it carefully, sweeping from left to right, scanning the whole of the septum at lower Nyquist limits. Now, then comes the evaluation of right ventricular outflow tract. As you can see over here, the turbulence starts just, quite below the pulmonary valve. This is the site of pulmonary valve. As you can see, this pulmonary valve is moving nicely. The leaflets are thickened, but it's moving well. So there is infundibular obstruction, which is much more than the pulmonary valvular obstruction. And then you can see MPA is of good size, RPA is reasonable size, and we'll further see that this RVOT can be further evaluated on subcostal view, which is equivalent to RA view of angiogram. Here, if you see, this is the aorta, this is the right ventricle, this is the right ventricular outflow tract, this is the deviated septum, this is the pulmonary valve, and this is the main pulmonary artery. And you can see the whole tract opened up where the obstruction is predominantly at the level of subvalvular or infundibular region. Now, then we calculate the pulmonary valve. As I said earlier, the pulmonary valve size is very important in determining what kind of surgery can be done. And this should be measured in terms of Z-score. You can use any online tool, something like parameters, where you can put the numbers and it gives you Z-score. So here, the pulmonary valve is nearly normal. So this patient most likely will not require transannular patch. Then you look at the branch pulmonary arteries, you measure the branch pulmonary arteries, the right pulmonary artery, and then the left pulmonary artery. Right pulmonary artery is also seen well in supraesternal view. Left pulmonary artery also should be seen in length, because the measurements which we want is distal pulmonary artery, and note the proximal one, because for the Magoon's ratio, it is the distal pulmonary artery which is used in calculation. Now, this is for coronary. If you are careful, then you can see that coronaries are normal in this case. But if it is abnormal, you would see something like this, where the coronary is crossing the RVOT, and this is a relative contraindication for transannular patch. Of course, not in this case, because this case has a good sized pulmonary valve annulus and would not be requiring a transannular patch. Then you look at the arch-sidedness. Here it is left-sided aortic arch. Don't forget RV size and function. So you look at the tricuspid valve annulus, you look at the RV function and LV function. You also look at the mitral valve annulus and the the LV size, so that later on you're not finding any challenges in the post-op period. So the final report what we would give is cytosolitis, levocardiac, concordant connection, single VSD, no additional VSD, aortic override, pulmonary valve annulus Z-score is good, good size pulmonary arteries. So this patient is suitable for TOF repair without transannular patch. Let's come to another example. 10-year-old boy, saturation 70%, hemoglobin 20 gram%, and these are the numbers which we'll be using for calculation. Subaortic VSD, aortic override, aortomitral continuity is present, and as you can see over here, large VSD, infundibular stenosis, pulmonary valve is not very well seen here. You need to make some maneuver, and you can see there is a tight infundibular stenosis at this point. Gradients are high, pulmonary arteries are a good size. Pulmonary artery right is 11, left is 17. But look at it. Now we are trying to scan the septum for VSD. There is no additional VSD, but is there anything else? And that is important that you look at this left ventricle. This looks dilated and dysfunctional. So it is important that you do a detailed analysis of ventricular function. As you can see over here, the EF is reduced. The same is being reflected on the IVC. As you can see over here, there is no inspiratory collapse in IVC, and this patient is actually having ventricular dysfunction, and that makes this case, this patient should get early surgery because he is already having dysfunction because of chronic hypoxemia. Now here, the pulmonary valve Z-score is -1.97. That makes it borderline for transannular patch. So you have to inform the surgeon that we think, or I think, that the pulmonary valve annulus is reasonable. We can preserve it with some bit of RVOT obstruction remaining. You may not need transannular patch, and that is a good news for the patient, because there is a transannular patch, there is free PR, and the long-term outcomes are not great compared to those who does not require a transannular patch. Now, when we do echo, we must recognize that congenital heart diseases always have some or the other surprise hidden, and associated lesions may always be there. So don't ignore, even if you have diagnosed Tetralogy of Fallot, you may still find another associated lesion, and you have to find and pick the clues. For example, here, there is a large subaortic VSD, aortic override, aortomitral continuity present, but look at this right ventricle. It hugely dilated. You have to find a cause for this dilated right ventricle. And here, if you see this coronary sinus is dilated, this patient actually turned out to have TA-PVC to coronary sinus. So such a thing can be picked if we have high index of suspicion, looking at what is not expected out of top is present in that particular case. For example, another 1.5-year or 2-year-old child who I saw maybe 7-8 years back, you can see over here again a large VSD, right ventricular outflow tract obstruction. Pulmonary valve is nicely seen here, good size pulmonary valve, but the gradients are relatively lower, only 45, something like that, and patient is saturating well. So what is the cause? If you do detailed analysis, you can see a membrane in the left atrium which is obstructed. So this is the gradient across this membrane. So why it is important to identify these associated lesions is, number one, it will change the timing of surgery for the patient. Number two, if these remain unidentified, surgeon may leave that behind and the patient will not be cured of the congenital heart disease. Imagine patient has corrected tetralogy but has left out this membrane. So you have to be careful whenever we are evaluating any patient of congenital heart disease. Another example over here, same large subaortic VSD, almost 50-60% override. On 2D, you can see the RV outflow is narrow, but turbulence is not there. Gradient is only 20-25. Another clue, the left ventricle is dilated. What was happening? The patient actually had a large AP window, which was causing PAH, and that is why, despite narrow RVOT, we did not find turbulence as you expect in Tetralogy of Fallot. Now, what are the clues here? Dilated left ventricle, and that is the clue. Low pressure, that is the clue. So we cannot and should not label this case as a VSD. If we label this case as VSD, then we will treat the patient differently. So if we diagnose the patient as tetralogy, but with aortic pulmonary window, aortopulmonary window, patient would benefit from early surgery. So echocardiography is also useful, other than whatever I said, it's also useful in identifying the need of early surgery. As I said, restrictive VSD, identifying cases which are not suitable for top surgery if there is severely hypoplastic pulmonary artery, coronary crossing RVOT, or if there are large multiple VSDs in a young child. It also helps us in deciding candidature and the type of palliative intervention like PVBD, if the valvular stenosis is dominant, RVOT stenting if it is infundibulary stenosis, and PDA stenting if PDA is patent. Echo still has some limitation if the windows are poor. For example, in adults and adolescents, aortopulmonary collaterals are not visualized. Occasionally, you may see multivalve VSD is a problem, and RV function sometimes poses challenge. Now, I will be talking in my second talk that sometimes for additional VSD, you may use saline contrast to visualize. If I play it again, you can see that there is additional jet of contrast going here. So that confirms the diagnosis of multiple VSD without doing invasive angiogram, which is otherwise the norm in these patients. So to summarize, for optimal echo for planning surgery for Tetralogy of Fallot, it is important to understand the basics of cardiac anatomy and surgical techniques, which we use contemporarily. Echocardiography is extremely useful in planning TOF surgery by deciding its approach, timing, need for transannular patch, and risk of post-operative complications such as restrictive RV physiology. Thank you so much for patient hearing.
Thank you, Dr. Sourabh. Wonderful lecture. Before we begin the question, can I ask one question myself?
Yes.
We used to have that PA sizes and size of descending aorta, is that still useful?
Yes, we still use it. Actually, I did not emphasize because I thought that is quite known. So Magoon's ratio we still use. Okay. And we measure the pulmonary arteries as distal as possible on echo, and aorta at diaphragm, and then we make that judgment. Sometimes that may not be applicable. So in those cases where we have to use absolute Z-score of pulmonary arteries, because in tetralogy, aorta may be disproportionately dilated because more amount of blood is going to aorta. So aorta size may be much more than what it should be. So although historically we have been using Magoon's, but I personally think that the absolute measurements of PA size, Z scores, may be a better way of doing it.
All right. Okay. Great. So there are questions. One of the question Dr. Anil Sood asked in the question, because there are questions in both sides, QA as well as in the chat box. Dr. Anil Sood is asking how common are the coronary anomalies in TOF?
So as I said, a 3 to 5% is major coronary anomaly. Minor ones like hypertrophied coronal branch may be there in more commonly, but I would put a number as 3 to 5% where we are having a significant coronary artery crossing the RVOT, which is of surgical significance.
Current, he also, wants to know what are the current indications of doing cath and angio, in a patient with TOF with such an excellent echo tools.
So it depends upon the institution to institution, number one. Number two, if the child is young, if echo windows are good and we are comfortable with all the things which we have seen, cath or any other imaging modality is probably not required. If the child is a little older, where our echo windows are not great, our accuracy and the sense of comfort with the imaging is not good, then we need an additional imaging. If we think that aortopulmonary collaterals are likely to be there, like in a patient who has significant desaturation, then soon, just before surgery, this patient may undergo a cath and simultaneously coil embolization of epicollaterals. So I would say two indications: one, aortopulmonary collaterals; number two, if there is a doubt about multiple VSD, because multiple VSD cannot even be seen on CT. So angiogram is the modality if you really want to exclude. And number three, I would say, if your findings are not matching, if your clinical findings are not matching with echo and you may be having associated lesions, then go for cath, because surgery is a big thing. You don't want to take chance.
I think the TOF is a very common disorder,
Yes.
which we see, and I don't mind discussing for a little longer time. And now there is a question by Dr. John. Please explain DORV versus TOF and isolated VSD with PS on echo as a differential.
So I went a little fast there, but I would say, so the tetralogy VSD is a malaligned VSD. So there is always an anterior malalignment of the septum. And there is almost always there is an infundibular obstruction. So if you are not finding malalignment or infundibular obstruction, it is not tetralogy. You may call it as VSD-PS physiology. Sometimes we do see subaortic VSD without malalignment or a muscular VSD with valvular PS. That is not tetralogy. You may take some clues for physiological understanding for managing the patient, but surgically it is not a tetralogy. Number two, about DORV versus TOF. So if it is a subaortic VSD with DORV, practically we have been using this aortomitral discontinuity, but we know from heart specimens and otherwise that criteria of 5 millimeter is not a good criteria. Sometimes we overmake the diagnosis of DORV. That is not to be done. If the override is more than 70%, then practically it becomes surgically significant, that the patch may be hampering with the RV volume. So I would say that if there is aortomitral discontinuity with significant aortic override, then you may start thinking as DORV. But I'm sure clinically these things, we need not be perfectionist. We may follow what is the current understanding with the surgeon available there.
I know, because I do a lot of fetal echoes, and there is a challenge. If I do a lateral LVOT view, the override is different. Go
Yes.
to an apical. Probably we've been using apical this thing to actually quantify. It's not issue of 50, 60 or 70%. We know up to 70% or maybe more, the decision doesn't change. The physiology is almost the same. So
Yes.
is the, prognosis and the surgery. But the important is, what do I write at the end of my report? DORV and TOF is once writing the report, it becomes a very a different name altogether and carried along, but doesn't it matter that
I
way?
think it is overplayed.
Yes.
I think
Okay.
it was overplayed. Override, we know the correct way of looking at override is in the short axis. When the
Okay.
aorta is in the short axis and you are looking at the septum. Now, unfortunately, echo doesn't provide lot many views like that. And that is why you keep changing the plane of the probe and you will keep changing the number, percentage of override. That is why in subcostal, a lot of the times override would leak more than the plex views. So that is not the challenge related to our understanding. That is related to the 3D structure of the heart. So that is why they say if you want to be sure, you do a cross-sectional imaging, you look from above the aorta. You look from the aortic valve inside into the ventricle, septum is here, and then decide whether it is overriding onto left ventricle or onto right ventricle.
So have you tried three-dimensional, and does it help? Like there are a couple of doctors who are working on a DORV with 3D,
For a
and
simple DORV with subaortic VSD, it doesn't really add
doesn't make any difference.
because
So you
surgeons
don't need
anyway
to.
would be able to close. When it is complex, yes, it becomes important. So we are talking about complex DORVs, not like TOF-like DORV. So DORV can be labeled as TOF-like DORV. I would say that practically that is the best balance you can achieve while writing a report. DORV, TOF-like. So that solves the issue because your aim is not the semantics. Aim is to treat the patient.
Correct. So I think you already mentioned, but still, Dr. Shrikant wanted to know that ideal age when the TOF has to be operated if it's not urgent.
So any time after 6 months is a reasonable time to operate a tetralogy child. If the child is having very good saturation, like say around 85%, 88%, then you may wait up to 1 year, 1.5 years, but you don't gain as such in terms of surgical results. You may get the same results at around 6 months, 8 months, 9 months of age. So I would say that elective repair anytime after 6 months as and when you diagnose.
And another question is to identify coronary anomalies, what about CT angio?
Yes, that can be a modality if echo windows are not good and there are no other questions like additional VSD, then CT may be done. A lot of centers prefer CT and that gives a lot of insights into many other things. So I find no reason why we cannot do a CT.
Good, Dr. Sourabh. I would wish to see those CT autopsies in case you have small clips maybe in between with your next talk or immediately after next talk, if it is possible.
Yeah,
Please show
I
that.
have.
I'm so excited to see that virtual autopsies.
Okay, I'll show some few things for 5
Yeah,
minutes so
yeah.
that it becomes kind of
Please
introduction.
do that. Yeah, yeah. So thank you very much, Dr.
Thank you.
Sourabh. It's been a wonderful presentation.